You need to have some HLA matching, of course. Like we like PTCy really can overcome someone that is matched at a 2 out of 8 level. So what we typically, I know these terms can be a little confusing. When we talk about fully matched donor, we refer to someone, we can check these matches or mismatches at many levels, but for general purposes, we call a full donor an 8 out of 8. This is someone, donor or recipient, matching at 4 proteins, A, B, C, and DR. Okay. And if you match at those 4, for all intent and purposes, you're considered to be fully matched. Okay. The trial was designed to test this strategy down to the 4 out of 8 level. Okay. But what is important to recognize is that we really don't have to go that low, because when you go down to the 6 out of 8 level, and this is through computer modeling and projections. I mean, remember that the donor pool the registry is very large. We have over 40 million donors. So when you really get down to the 6 out of 8, we know through modeling that you can find a donor for any patient, irrespective of the race and ethnicity. So yeah, to answer your question, there is a limit, of course. We can't do a 0 out of 8 or a 2 out of 8. We can go down to 4 out of 8, but we really don't need to. Yes and no, right? Okay. So what 6 out of 8 means that at that level, you can identify a donor for every patient. Okay. But I think we're trying to move away a little bit from the notion that 7 out of 8 is better than 6 out of 8, and 6 out of 8 is better than 5 out of 8. The data, what we have so far, shows that when you use the PTCy platform, the degree of mismatch doesn't seem to matter much. In a way, yes, the 6 out of 8 is a sweet spot, but I want to be clear about the fact that we don't prefer necessarily a 6 out of 8 over a 7 out of 8, or it's just at a registry level. When we become permissive to that degree of mismatch, then you're truly opening up the pool for everyone. The main reason for treatment failure in mismatch transplantation, related and unrelated, has been historically very high rates of graft-versus-host disease. And subsequently, with that comes other problems, right? You have to give more steroids. You get high risk of infections. You can have graft failure. The transplant can be rejected. So, but the main reason is, yes, the driver of that mortality, it's graft-versus-host disease, which essentially meant that 5 out of 8 or 6 out of 8, or definitely a 4 out of 8, were just prohibitive. Even if you could identify that donor a few years back, it didn't mean much, because that was not a donor you were ever going to offer to any patient, no matter how bad the donor options were or how desperate we went to take that patient to transplant.